What I want to do today is talk about targets and outcomes of psychotherapies. And that's a bit of a strange subject because I'm mostly a researcher. I've been working in clinical practice, but that's a long time ago. But when I look at research, we mostly just focus on symptoms of disorders. So we've been doing a lot of meta-analysis on all kinds of things, mostly psychotherapies of depression. And then you just focus on symptoms of depression as the most important outcome. But that's not, as you know, that's not what patients only come from. Patients find that very important to have their symptoms reduced. But it's not the only, they just want to go back to work. They want to be a good mother. They want to stop the fights with their partners, that's over. So they have really very different focuses. And so what we do in research is actually pretty reductionistic, so to say. And what I want to do today is I want to focus on that question a little more. And so I want to look at these targets and outcomes of psychotherapies from all kinds of different perspectives. So symptom reduction, but also what do patients think? What do health insurance companies think? What does the society at large think? So that's what I want to focus on. The broad line of what I will talk about is written in this paper that was published last month in World Psychiatry. And I must say that the idea for this paper actually started because of a discussion with Professor Mai, who started this whole idea of what are exactly these targets and outcomes of psychotherapy. And this paper is the result of that. What I will do is I will go through all these different ways of looking at targets and outcomes, and I will try to summarize what we know about these different targets and outcomes of psychotherapies for the different mental disorders. But within that, to get a more complete picture of that, I will focus specifically also on psychotherapies for depression. And that's because that's what we know most about. And in my group, we have databases. We keep up the literature of what's going on in the psychotherapy field. So every year, we collect all the trials that have been done in depression, but also in anxiety disorders. So we have these databases of outcome studies, and we've all this information from meta-analysis to see what the outcome is. So because depression is by far the best studied disorder in psychotherapies, I will try to give more details about that, just to give you an idea of what's going on if you look at these different outcomes. Actually, it starts with a problem that we really don't know what mental disorders are. Because we have defined mental disorders as if they are a group of symptoms, but we don't have a blood test or an objective thing to measure what a disorder is. And for example, in depression, we just say if somebody has 5 out of 9 symptoms, that's a major depressive disorder. But in reality, we know that that's not the case, and it's a continuous thing, depression. It's not there or not there. It's something that is there in everybody at some point in their life, in more or less, and you can pretty much better look at it as a continuum. And so what we did when the DSM started, we said, okay, we have these symptoms and we take a cluster of them. We know it exists because we see a lot of these patients. And then we define this as a disorder. This is depression, or this is generalized anxiety disorder, or this is a psychotic disorder. But that's only based on clinical observations and consensus. So, but we really don't know what it is, what the processes are that lead to it. There's very little prospective research in people who have nothing and who develop a disorder, and what these processes actually are. We really have no clue. So if you try to summarize it in a very brief way. And so, but if we don't know what it is, where should the treatment focus on? That's a pretty complicated question. And so if you have a pure psychiatric perspective, you could say, okay, yeah, but we have these disorders, we have these symptoms, 5 symptoms out of 9, and we try to reduce these symptoms, and then problem is solved. But psychotherapists don't look at it like that. If you're a psychodynamic researcher, you consider symptoms of, for example, depression. They're not really the key issue. The key issue is your personality that was developed in your early life, and all these attachment issues that happened during your early life that made you the person you are now. And that's how you are. The problem is how you are, that you cannot function as you are. And depression, that's just one of the outcomes of it, but it's not the key where you should focus on. So it's really pretty complicated if you look at what these outcomes are of psychotherapies. So, and as I said, it really depends on the perspective. A patient has usually patients want the symptoms to go away, but they, as I said, they want to be a good parent, stop the fights with their boss, or go back to work, or things like that. These are at least as important for patients. And therapists, they also look at it from completely different perspective. CBT people, they agree with focusing on symptoms, but not psychodynamic researchers. And also people from the more, how do you call it, the Rogerian schools, the more counseling schools, they also don't think that symptoms are the most important things. For researchers, it's usually clear. Symptoms, you can measure them and you can look at the outcomes, so that's very clear. But as I said, it really depends on who you ask what the most important outcomes are. And so I will now try to focus on the most important types of targets and outcomes and summarize what we know about it. So symptoms are, if you look at outcome research, they usually look at symptoms. And that's what I will show you later on. If trials are done, outcome studies, open studies, trials, whatever, they always look at symptoms. That's the primary outcome of all the studies. And it's also obvious that this is important for all stakeholders, because this is what we consider the key of psychotherapy outcomes. And if you look at these outcomes, there are literally hundreds of randomized trials and dozens of meta-analyses focusing on it. And so I will first show, I go too quickly. Yes, so what we did in this paper, we took the largest meta-analysis in each of these fields for each of the disorders. And as you can see, for depression, there's a lot of research, 369 trials, but also in social anxiety disorders, panic, generalized anxiety disorder, PTSD, OCD, bipolar disorders. Psychotherapies seem to work in terms of reduction of symptoms. So you see the number of studies, the effect sizes. Effect sizes are always a bit complicated because they indicate the difference between a treatment and a control group in terms of standard deviations, which is nice for researchers, but if you ever try to explain this to a patient, I'm pretty sure that patient won't understand what you're talking about. So I also gave the numbers needed to be treated. So how many people do you have to treat in order to have one more positive outcome than no treatment? So these are all trials comparing psychotherapy to control conditions, waiting list, care as usual, pill placebo, or other inactive control conditions. And then the effect sizes are pretty large, with numbers needed to be treated pretty impressive. Except for psychotic disorders, that's a bit more complicated. I won't go into that now. But also for psychotic disorders, you usually find better outcomes, not very big effect sizes, but some outcomes, especially of CBT. Let's see. What is a problem, if you look at these meta-analyses, is that they overestimate the effects. And that's something that we've shown many times. They overestimate the effects because of publication bias, allegiance of researchers towards their therapy. They want their therapy to be more effective than other therapies. Design problems, how patients are randomized, whether you do intention to treat analysis and all that. But even if you do that, the effects in most disorders remain significant. One thing that is very much in line with what Ron said is that if you look at these trials in depression, for example, so we have this database of depression trials. There are more than 35 outcomes for depression. 35 measures of depression in psychotherapy research, which is not true in pharmacotherapy because almost all studies use the Hamilton, but in psychotherapy it's the BDI, also the MADRS, and all kinds of other clinician-rated outcomes. What is also true is that in a lot of psychotherapy research, self-report measures are used instead of clinician-rated instruments. And that can introduce a bias, so you want to have an independent judgment about the outcome. On the other hand, what we did one time is if you look at the actual outcomes, self-report measures are more conservative than clinician-rated measurements, and that with an effect size of 0.2. So I don't know, I'm not sure, but that's only in depression. So if I want to go into a little more for depression, because as I said, we have so much information about that. And so what you see, these are the different types of therapy, and we have CBT, behavioral activation, interpersonal therapy, problem solving, all doesn't matter. The effects are pretty much the same, and if you look at all kinds of comparative outcome studies, they all indicate that therapies have all these different therapies have comparable outcomes, and there's no significant difference between therapies. It does matter which kind of control group you take. Waiting lists probably overestimate the effects of psychotherapies. And you can, the research on that is pretty clear. If you use waiting list control groups, the effects are much larger than when you use care as usual or placebo or other kinds of control groups. Probably that's because people are randomized to two conditions, and they hear that they either get the treatment right away or they have to wait for 3 months to get this great new therapy developed by this famous professor and it will almost certainly help you with your disorder. You only have to wait three months. And so dropout during waitlist is very low because everybody wants this treatment. But what actually happens is that you stimulate people not to do what they would usually do to solve their problems. So you artificially tell them don't do anything because you get this great therapy in a while. And if we did all kinds of meta-analysis of network meta-analysis. We're replicating this one now. This has about 200 studies, but we now have many more. But I don't expect that the results will be very different. It indicates that the type of therapy is not related to the outcome. You can do psychodynamic therapy, you can do CBT, interpersonal therapy, all doesn't matter. That doesn't mean that you can do anything. So it doesn't mean you can just talk with somebody and then it also will be good. These are all manualized, well-developed therapies where people are trained to deliver them. So I'm not going into e-health today. That's in my group. That's one of the things we do a lot of research on. If I had known that, I would have spent a few more slides on this. But what we did, and I will briefly go into this. So what we did a couple of months ago in JAMA Psychiatry, we did a network meta-analysis of treatment format. Does it matter whether you deliver therapies individually, in group, by telephone, by guided self-help, give people a book and call them once a week, or deliver the guided self-help through the internet with coaches? In England, they call the people who deliver this psychological well-being practitioners. They're paraprofessionals with a training of 6 months to deliver guided self-help through the internet or otherwise. And so we had I think more than 150 studies of CBT, and this is what we found. We found no significant difference between treatment format as long as there's a human involved. So whether that's a coach or a highly trained CBT therapist, or if you do this in groups or by telephone, doesn't matter, the outcomes are comparable. No significant difference between the effects of CBT delivered in any format as long as a human is involved. So if there are also all these kinds of unguided internet interventions where you just go to a website and you learn how to apply CBT techniques on yourself, but without a human to support you, to give feedback, to stimulate you to go on. And these interventions are more effective than waitlist, but not more effective than care as usual. So overall, we have to conclude that any format works as long as there's a human involved. We found, just to summarize, I could talk a whole day about this, sorry about that, but we know a lot more about psychotherapies for depression. So age is not a relevant issue. It works in younger adults, older adults. The old people who are 70 years or older, effects are comparable. Whether people have heart disease, diabetes, cancer, not related to outcome. It works just as well. If it's postpartum depression, perinatal depression, the effects are comparable. What we do know is that the effects are probably smaller in chronic depression, although that's also a more complicated story. The effects are almost zero in comorbids if people also have comorbid substance use. So if you treat people with alcohol disorder and depression, the effects are very small, and it has hardly any effect on alcohol use. This research on psychotherapy is mostly something from high-income countries, But in the past 10 years, we see a huge increase in number of trials in other countries, especially East Asia, China, Japan, but also Southeast Asia, India. And what you see is that these trials in low and middle income countries actually show that psychotherapies are more effective there than they are in high income Western countries. Yeah, an interesting thing, what is why health insurance companies like to invite me to give talks, is that the number of sessions is not related to outcome. And whether you offer 6 sessions or 24 sessions, that really doesn't matter. And we could not find, so we did meta-regression analysis to look at the number of sessions as an outcome, and it doesn't matter. We looked at contact time, so the number of sessions times the length of the session, not related to outcome. What we did find is that the number of sessions per week matter. So if you have 2 sessions per week, the effects were larger. But of course, this is correlational research, and it's not, if you look at moderators in meta-analysis, that's not causal evidence. You have to be very careful with that. So we did a new trial, from which we have the results now, not published yet. But we did find confirmation of that if you have 2 sessions per week instead of 1, that the effects are larger. Okay, because this is a psychiatry conference, I think it's also to say a few things about pharmacotherapy. So very briefly said, at the short term, psychotherapies and pharmacotherapy have comparable effects. No significant difference between drugs and therapy at the short term. At the longer term, probably psychotherapy is a little more effective than pharmacotherapy. So there are these studies in which people get CBT, and then during the year after that they get nothing. And people in the pharmacotherapy, they get pharmacotherapy, but also continue to use drugs during the year after that. And what you see is, at the end, there is no difference between these 2 groups. And there's even a small benefit in favor of CBT, but that was just not significant, 0.06. But you can say that at least the effects are comparable. And if people stop taking drugs during this 1 year after the acute phase treatment, then psychotherapy definitely was better, and that was highly significant. But what we also find is that combined treatment clearly is better than either one alone. So with the effect size of drugs versus placebo, that's also the effect size of drugs versus combined treatment. What we did find in a accepted paper, which is not yet published but will be published soon, is that also what we also found is that the acceptability of combined treatment and psychotherapy is higher than the acceptability of drugs, significantly. But what we also should remember is that the effects of psychotherapy are heavily overestimated. That's not, by the way, not only true for psychotherapy. Same problems are in research on drugs and not only in depression. We know these problems are in the whole biomedical field. One thing is that I already mentioned the use of waiting list control groups, which overestimate the true effects. If you look at risk of bias, we use the Cochrane risk of bias tool, and we found that about 70% of the randomized trials have some risk of bias. Publication bias, we've examined that directly. We looked at the NIH studies funded that funded trials for psychotherapy for depression, and looked how many were published and how many were not published. And one of the researchers in that group was Steve Holland, who is a very persistent man, and he went after the people who didn't publish their results, and he got the data. So we could compare the published and the not published data. And we saw that about 1/4 of the funded trials were not published. And if you adjust for that, the effect size goes down with about 25%, which is very much the same as what Eric Turner found in his 2008 New England Journal of Medicine paper of publication bias in antidepressants. So this is what happens if you adjust for the most important of these things. So if you look at all these studies, the effect size is 0.63. If you exclude the ones with a waiting list, it goes down to 0.51. If you only take the studies with low risk of bias, then it goes down to 38. And if you adjust that statistically for publication bias, then you end up with an effect size of 0.31, which is about half of what you would think if you would just look at all the studies and trust them all that they have done good research. And this is not only true for depression, because in depression we have the advantage that we have all these several hundreds of trials. In most other disorders we don't have these data, but we did a meta-analysis also of anxiety disorders, and we found the same pattern. So I always thought that anxiety disorders can be very well treated with psychological treatments. But if you really look at the research, that's mostly because these studies almost all use waiting list control groups. And if you look at the other studies, the effects are pretty much comparable to what we find for depression, much lower. And risk of bias is also here a huge problem. Okay, this is a summary of what we know about the effects of psychotherapies on symptoms. And as I said, symptoms are the things we mostly focus on in randomized trials, research on psychotherapies. But if you ask patients, they say, yeah, symptoms are important. Of course I want to get rid of my depression, but it's certainly not the only thing. And if you really look into the literature, there's a pretty long tradition of research going back to the 1960s in which patients are asked in a different way what the outcomes of psychotherapies are. And the difference is, so if you look at symptoms, they are what we can call nomothetic outcomes, while ideographic outcomes are unique outcomes, like the patient saying, I want the relationship with my partner improve. That's only important for this patient and may not be important for other patients. And there are all kinds of measurement instruments available to measure these things. That's not done a lot, but it does. But the studies that do that, they are actually pretty interesting if you read them. And but it's not a strong tradition, and it's not large, or there are not all these dozens, hundreds of research groups like there are on outcome studies for mental disorders. But this is, for example, one study found 4 categories of outcome, saying establishing new ways of relating to others, which they considered an important outcome of therapy. Reduction in symptoms is, of course, an important, but also change in patterns of behavior, or better self-understanding and insight, and accepting and valuing oneself, which in clinical practice we know these are the things that indeed matter. And it's such a shame that we don't do this more in research, because it's actually the thing that we should be focusing on much better. Yeah, and then we have quality of life. That's nobody knows what it is. There are all kinds of definitions of that, but there's a highly debated thing on what is quality of life. There are measures. So and it's pretty, what happens a lot in research on psychotherapy for mental disorders is that it's often a secondary outcome. So here is what these are meta-analysis of the effects of psychotherapies for these mental disorders on quality of life. And what you see is that the effects are, they're not that bad for most disorders. Again, psychotic disorders, schizophrenia is a bit more complicated. But for anxiety disorders, depression, eating disorders, anxiety disorders, we have pretty good evidence that psychotherapies can improve quality of life. In depression, we have much more, how should I say that, more detailed information. So in our databases of trials, we can look at all the other outcomes, and we have all these trials also looking at social functioning, suicidality, social support. And so usually what you find for most studies is that if they find a good outcome for depression, they also find a good outcome for quality of life, social functioning, social support, etc. Interestingly enough, there's very little research on the outcomes of treatment of depression on suicidality. We found only 4 studies, which is a bit weird because most guidelines say that if you have a suicidal patient with depression, you should first treat depression to see whether suicidality goes wrong. But it's ignored in this literature, interestingly enough. There's also an interesting group of studies in depressed mothers, which looked at the mental health, the outcome of therapy for the mothers on the mental health of their children. And they did indeed find a significant outcome. And on parental functioning and mother and child interaction, etc. Yeah, and then we get, I have 8 minutes left, so I have to be quick. So the next thing is mediators and moderators. So if you, as I said in the beginning, it really depends on the type of therapist you ask what are the core outcomes. So a CBT person would say, no, you have to focus on dysfunctional thinking, because if these thoughts change, then the depression will go away. But if you ask a psychodynamic person what the core outcome is, that person will say, no, symptoms they're not relevant. You should focus on the personality. You should focus on on the inter-psychic dynamics of this person and why he feels all these problems. And that's the core thing you should focus on in psychotherapy. The problem is that we have, for none of these models, there's very much evidence. And that's related to the fact that it's relatively easy to examine whether a therapy works, but it's much more complicated how it works. So we have randomized trials in which we have this group of patients which we split in 2, and half of them get a treatment. And so after a couple of months, if we find this difference between these 2 groups, that's scientifically that's very strong. It's an experiment. So there's no stronger scientific evidence than the evidence from a randomized trial. But that you can use that to examine whether a therapy works, but not how it works. That's much more complicated. It's like saying, okay, we know that tobacco, that smoking causes cancer, but what exactly happens when somebody inhales this tobacco? What happens in the lungs? How does that go into the blood? What are these processes leading to the onset of cancer? I read a paper about that. We don't know that either. So some parts of these processes are known, but not exactly. Same here. We know that therapies work through this strong experimental design of randomized trials. But how can you examine how they work? We hardly know anything about that. And that's, some people say, yeah, but we know this from CBT. No, we don't. So there is a lot of research on cognitive thinking. Is that a mediator? So is this, do we have evidence that change in cognitions precedes the change in depression? And is that the core issue in CBT? No, we don't. Also not for depression. And that's and we don't know that for any of the other processes of psychotherapy either. Yeah, I wrote, if you want to know more about it, I will skip this. I wrote a paper about this in the annual review of clinical psychology earlier this year. So the basis is that we just don't know anything about this, hardly anything, because it's so difficult to examine. And that's the same as what Ron said in the previous talk. If you want to examine this, you need huge trials. With a trial with 200 people in each arm is not enough. You need trials with a few thousand patients, with lots of potential mediators to examine the actual mechanisms of change. Yeah, I will skip this. Yeah, and then the other thing is negative outcomes. That's something which all of us know very well. First, do no harm, which is an important thing in the whole biomedical field. But it has not been examined extensively in psychotherapy research. It's about 10 years ago that an important paper was written about this in the American Psychologist. And everybody agreed, but nobody did anything. So we still know very little about potential negative effects of psychotherapy. It's also not very clear what it is. Is deterioration, real adverse events, or non-response or dropout? Are these negative effects? Yeah, depends on how you look at it. We know there are some harmful therapies which you shouldn't do at all, like the rebirthing thing, debriefing after traumatic events. We know from randomized trials that they work negatively, so you shouldn't do them at all. But it is very well possible that effective therapies on average are beneficial, but that still individuals can deteriorate because of that. Yeah, for depression we know something. So what we do is we do all these meta-analysis, but for some of them we collect primary data, and then we can examine for each of these individuals how many actually get worse. So we can examine how many of them get worse. And then you see that the number of people who deteriorate is lower in therapies than in control conditions. And that's also true for antidepressants, which we published some time ago. Yeah, economic outcomes. I will be very brief about this because this is a complete field. I mean, economic outcomes are highly relevant from a societal perspective, from health insurance companies. But it's really a separate field. And unfortunately, it's hardly examined in psychotherapy. There's a little research in depression, but for most disorders, like bipolar disorder, OCD, anxiety disorders, PTSD, there are 1 or 2 economic outcome studies. For depression, there's a little more, especially in the past couple of years in internet-based CBT, and most of them point at positive outcomes, so that you reduce the costs with innovations. But that's not true for all the studies, so we don't know. So I come to my conclusions. Unfortunately, we still don't know very well what mental disorders are. And therefore, it's very unclear what are the best targets and outcomes. And it really depends on the perspective. But if you ask me, I think it's important that we start listening more to what patients think is important as outcomes, and that we include that more also in research. But for most of these outcomes, we don't have a consensus about what are the best ways to measure them. And we really need a consensus about that.